What's in the pipeline for male infertility? This discussion has been made possible thanks to the support of the Scottish Government, so it gives me great pleasure to introduce Dr. Sarah Martins de Silva. She is a clinical senior lecturer in systems medicine at the University of Dundee.
I want to present some research that we are currently doing in Dundee, and I've kind of go with a bit of a football theme to kind of embrace the whole Euros thing that's going on. And my talk is called It's a Game of Two Halves. And what I really mean here is obviously there's the egg and the sperm, but we're really going to concentrate on the sperm today. So fertilization failure and sperm. So this is the current state of play in clinics as it speaks at the moment. We do diagnostic semen analysis by getting a guy to produce a sample, and we look down a microscope and we assess of sperm, how they're swimming and how they look in great detail. And for those of you that are unfamiliar or less familiar with the kind of standard of fertility criteria, then we're looking really for a sperm count of somewhere in the region of 15 million per mil or greater. About a third of those sperm swimming in a meaningful way, so 32% fertility and 4% normal morphology. And we use that really then to characterize treatment for those that require assisted reproduction technology into IVF, where a sperm is prepared and added to the egg, and ICSI, where, as Sarah very eloquently described, a single sperm is injected into each mature egg to achieve fertilization. Now, clearly there is intrauterine insemination in that list of treatments that are offered, but personally I would say that if a couple are having unprotected intercourse regularly, I'm not sure that that really has a great deal to offer over and above natural conception. So the reality is that following IVF ICSI, not every egg will fertilize. We see somewhere in the region of 65 to 75% fertilization rates in most clinics. But 5 to 10% of IVF cycles and up to 3% of ICSI cycles, there are no eggs fertilized, total fertilization or TFF. And a further group of patients may be affected by unexpected low fertilization. And quite how you characterize that depends on which definition you go with, but less than 25% or less than 30% of all eggs fertilized. It's uncommon, but clearly this is a devastating event, both for couples that have gone through quite involved treatment, as well as the clinicians in the lab and the clinic staff that are looking after them. So why does it happen? So we think about when we have a case of failed fertilization, we look at what we've done in the clinic. Are there any lab, the media, the temperature, any equipment that may have malfunctioned? But these issues are extraordinarily rare. We then think about the stimulation and the quality of the eggs that we have in the treatment. And then we think about the sperm sort of side of that equation, if there's an obvious issue with perhaps frozen thawed sperm or poor sperm function. And this, one of my focuses of research kind of lies within, is trying to understand and unpick this a little bit more. So there's a huge variety of different requirements that a sperm needs to bring to the equation to achieve fertilization, both naturally in IVF. Obviously, by injecting the sperm into the egg, we overcome most of those physical characteristics and requirements and barriers that exist. But yet still, when the sperm arrives in the egg, it needs to activate and tell it it's been fertilized. And so there's an increasing recognition that not only does the sperm bring to the of fertilization its DNA, but it also contributes a vast other kind of element in terms of both epigenetics, but also messenger RNA that it brings with it, and proteins that are required for fertilization, and also with a knock-on effect for early embryo development. And this slide kind of characterizes quite nicely the various different elements that we shape that sperm bring to that equation. And again, just to highlight, this is one area, oocyte activation, that I'm particularly interested in, and these two particular proteins, PLC zeta and PORP. Now, PLC-zeta is phospholipase C-zeta. Phospholipase C is an enzyme. It's a little protein, and it cleaves phosphates, and there's different subtypes that exist within different cell lines. But the one that we are particularly interested in is this one here. It's called phospholipase C-zeta, or PLCZ1, and it's completely unique. It's not expressed in any other tissue of the body apart from the testes, and specifically within sperm. And we now understand that this protein plays a key role in oocyte activation. It tells the egg it's been fertilized. So here is a picture of Hampden. Obviously, it's a beautiful football stadium, but I'm going to use this as an analogy for oocyte activation. So if it's the egg, when you have the arrival of your favorite football player into the stadium, the crowd in the seats, because yes, this is a pre-COVID kind of theory, go wild, and it sets off a Mexican wave of activity across the stadium. And that's my kind of analogy for what happens when a sperm arrives in an egg. It sets off a Mexican wave of calcium oscillations, calcium signals that go up and down and tell that egg it's been fertilized, but also then trigger downstream cellular events that drive then meiosis, completion of that, and early then cell division and embryo development. So as I've mentioned, 5 to 10% of IVF and up to 3% of ICSI cycles, there's no fertilization at all. And although that kind of the reason behind that is quite complicated, if you break it down into issues that might arise within the lab or within the clinic, they are extraordinary. There may be issues within stimulation response, or the number of eggs retrieved, or poor egg quality, some of which may be modifiable by changing stimulation or protocols in a subsequent treatment attempt. But I would argue that sperm dysfunction, problems with the sperm, are common and therefore are likely to be the most obvious cause of a fertilization problem. And so quite a few years ago, I set up a fertilization abnormalities or a sperm studies clinic. And the idea was that we would offer couples that had been affected by total fertilization or unexpected low fertilization the opportunity to participate in research that we do within Dundee. And we would look at each of the treatment cycles. We would exclude those where there was an apparently egg kind of related cause, or perhaps an unexpected lab issue, and focus on those couples where there was no obvious explanation, and offer them to participate in a number of research studies to investigate, amongst other things, sperm swimming, motility, and sperm function. So one of the things that we did at that time was we collaborated with the University of Oxford, and we found that by using certain immunohistochemistry techniques, so using a fluorescence labeling to pick out PLC-zeta in the sperm, that we could then compare how many sperm within a sample and how much of this protein was present within the sperm compared to donors or fertile men who we knew their sperm would fertilize eggs normally. And we could pick out patients where there was an issue with either the number of sperm that expressed PLC-zeta that was lower, or we could find less amount of that particular protein per sperm cell. And then we could use that to direct towards what we did next in terms of treatment options, in terms of trying to overcome oocyte activation deficiencies. So we published this paper a number of years ago now, confirming that this was indeed a research process that we could validate. And then in Dundee, we have now tried to move forward to assess more sperm from bigger samples in a more robust way using flow cytometry. So a similar idea, using a fluorescence tag on the protein to analyze the amount of protein within populations of up to 10,000 cells. And what we see in a sperm ejaculate is that some sperm express a lot of PLC-zeta, some sperm express little, and some express none. And we then kind of can divide those populations into those that have a small amount and a high amount of PLC-zeta. And if we look at just volunteer donor samples, clearly there's always likely to be a degree of biological variability in one sample or the next. But what we can see with these same individuals is that there's similar amounts. So if a guy has a very high amount or a very low amount, week by week, there's likely to be a similar result. So we've kind of got the confidence that we thought that this was an approach that was valid and worthwhile pursuing. And we've started now to roll this out in patient samples to try and understand patients and how their fertilization events occur in a bit more detail. But this is still in quite an early phase of development. In the meantime, though, we've accumulated a case series over time, 50 couples who have undertaken 68 cycles of treatment. And it's about half and half, so 34 IVF cycles, 23 of those affected by no eggs fertilized at all, and 11 cycles where they've had low fertilization, somewhere between 5.9 and 25%, which is what we've used as our cutoff. Similarly, 24 ICSI cycles, 12 affected with failed fertilization, the other 12 affected by low fertilization. The average age between the two groups, IVF versus ICSI, is very, very similar. The number of eggs retrieved is also very, very similar. So the usual event when you have a problem with fertilization following IVF is that we would move couples then into a subsequent cycle using ICSI. And you can see that most of the cycles where they've had very low or poor fertilization or no fertilization, in a subsequent cycle, the eggs have performed and fertilized very much better. But actually, in this patients, there are still 4 that have astonishingly low fertilization. And then what about those that have ICSI and then have an issue with fertilization following ICSI? Well, we have 3 options. One is that we repeat ICSI again. Maybe we change the protocol or the stimulation a little, but we run the risk perhaps of facing this in a subsequent cycle. An alternative approach would be to use donor sperm, an alternative sperm source that is likely to perform much better and fertilize the eggs well. But that's a huge culture and shift of moving from what a couple wish to do using their own biological eggs and sperm to something very, very different, and it isn't acceptable to all. And a third approach would be to think about artificial oocyte activation. The commonest approach is to use calcium ionophore, so it's an extra calcium step where the eggs after ICSI are a calcium media. And this is termed one of the HFEA add-ons. So this is an optional extra. It's quite controversial. First published case reports from back in 2010, and we added it to our treatment license in 2014. Basically, when we've done the PLC-zeta assay, we found about 1/3 of couples have got an issue with low or no PLC-zeta expression. And these are our results from artificial oocyte activation to date. So to date, we've done 38 cycles for 31 couples, and 15 children have been born as at shutdown last March. So a very promising technique that is now available within clinics in Scotland, in Dundee, and with significant clinical benefit. So in conclusion, I would argue sperm dysfunction is a significant element of apparently unexplained total or unexplained low fertilization. We see a deficiency in this protein in about 1/3 cases. There are some concerns regarding artificial oocyte add-on as a step in IVF, but I would argue this is a really valid option for some couples. But we still need to improve and validate a screen so that we can identify PLC-zeta protein problems.
Jamie is Head of Clinical Development at St George Street Capital, developing a clinical trial programme to investigate a potential new therapy for idiopathic male infertility.
So, on the 11th of July, Wembley Stadium in London is going to host the finals of the Euros Football Championship. And as ever at this stage in the competition, I feel incredibly optimistic about England's chances. We'll see where we are in a couple of weeks. Now, on that night, there will be 45,000 people in the audience. And if we assume that around about 30,000 of those will be adult men, there's about 2,000 men in the stadium that evening that will have some kind of fertility problem. And of those, somewhere between 600 and 1,000 might be considered idiopathic male infertility, and I'll talk about what that is in a minute. The number of men that will be taking an approved treatment for that condition will be 0 because there isn't one. Today, I'm about a tablet that is in early development but has the potential to change that situation. I'll just find the next slide button. There we go. So first, I'd like to introduce the charity that's leading this research, St. George Street, and then I'll explain why AZD5904, which is the drug, is such a promising prospect for this condition, and then I'll come on and talk about the clinical development plan. So St. George Street is a medical research charity that was set up about 4 years ago to find and develop drug candidates that have stalled in the pharma pipeline in pharmaceutical companies. And there are a lot of products, maybe 10,000 or so, or thousands certainly, of candidates that make it so far through development, only then to be deprioritized, so effectively put on the shelf, despite having the potential to become a life-saving or life-improving treatment. So our strategy at St. George Street is access to those compounds with the pharmaceutical company. We then select those that we feel have the best potential to become a new treatment in an area of unmet need. The drug is then gifted across to the charity. We take it through the next stage of clinical trials. If the data is positive, the pharma company can license it back, and the money that we then take for that is reinvested into new projects. And that product can then go into late phase studies and hopefully then get approval to go on to patients. And that, in a nutshell, is how St. George Street accelerate treatments to patients. So now let's focus in on idiopathic male infertility and why 5904 has the potential to treat this condition. So almost 1 in 7 couples suffer from infertility, and in half of those cases, the man is at least contributing to that infertility. Now, sometimes the cause of that infertility is established, but very often sperm abnormalities are seen, but the cause is not clear, and this is known as idiopathic male infertility. And it affects a huge number of men, as I illustrated in my first slide. And it also appears to be a problem that is getting worse. There's now data to show that sperm quality is declining significantly and has done over the last 4 decades. And as I mentioned, there are no approved drugs for this condition. ICSI is actually the only treatment available for couples that are in this, and that is expensive. There's obviously no guarantee of success. And as Sarah mentioned in her introduction, there's a very high burden on the woman. So there is a clear unmet medical need and even a demand, I would say, for a treatment that men can take that have this condition. The question is, what does that treatment need to look like? Now, we know that % of men with idiopathic male infertility have oxidative stress in the semen. So oxidative stress is something that occurs in the body when there is an imbalance between antioxidants and reactive oxygen species. And this can happen for a number of reasons. And I've put a few examples in the bottom left-hand corner of this slide. So when you get this imbalance, you get an environment of oxidative stress, and that can damage cells. And sperm cells are particularly vulnerable to this kind of damage. And what's more, they lack the repair mechanisms that are necessary to fix the damage once done. Now, and it plays a key role in the generation of reactive oxygen species is called myeloperoxidase. So if we can reduce the activity of myeloperoxidase, we might be able to restore this balance and then reduce or eliminate this oxidative stress, improve sperm quality, and improve fertility. And that really is the premise of this whole project, because AZD5904, the drug, is in fact a myeloperoxidase inhibitor. As the name suggests, this is an AstraZeneca drug. It's been through 5 prior clinical trials, and 181 people have taken the drug before at different doses and for different durations. So we have a good body of data. The drug has a good safety profile. What's more, there's a really clear relationship between the concentration of drug in the body and the level of myeloperoxidase inhibition that we then see. And that was really important in terms of defining which doses we wanted to look at in our first studies. What's really exciting is this next box on the slide. And this actually Dr. Martins de Silva has generated with others. And she showed that AZD5904 significantly improved sperm function in an in vitro model, so a laboratory model of oxidative stress. So that's really exciting. So we've got some very important data, some strong data. We've got a great hypothesis. Now what we need to do is build on that with clinical trials. The clinical plan. So St. George Street plans to do 2 studies. We're going to do a phase 1B and then a phase 2 trial. The phase 1B will be in up to 42 men with a history of idiopathic male infertility. And we're going to look at 2 different doses of the drug against placebo. And I'm really pleased to say that Dr. Martins de Silva will be our chief investigator for this trial. And we're going to run the study at Ninewells Hospital in Dundee. We've got a really simple study visit design. Men that would like to take part will attend a screening visit. And if they're eligible, they're then randomly allocated to one of those 3 treatment groups. They then start a 10-day course of tablets and return on day 5 and day 10 for visits. And then at the end of the course, they come back 1 week later for a follow-up visit. And at each visit, they will have a blood sample collected and a semen sample. And these samples allow us to investigate our objectives for the trial, which I'm going to come and talk about now. First, let's just remind ourselves of the hypothesis. MPO activity that reduces oxidative stress. It creates a less harmful environment for the sperm, which should improve sperm quality and improve fertility. Now, there's one other important question that we want to answer in our first study, which is, does the drug get into the seminal fluid, and if so, at what concentrations? So in our phase 1B study, our primary objectives, our primary focus is going to be the 2 boxes on the left-hand side, looking at concentrations of the drug in seminal fluid compared to blood, and looking at reductions in MPO activity, again, in seminal fluid compared to blood. Our key objective will be to look at reductions in oxidative stress. And we're also going to start to explore whether we can see improvements in sperm quality. Now, bear in mind, this is just a 10-day course of tablets. And we know that it takes more than 70 days for sperm to fully mature. So we might expect a longer treatment period may be necessary to see those full potential benefits of the tablet quality. But what we want to do is get this mechanism confirmed first with the phase 1B study. And that data will then support us justifying a larger phase 2 trial where the focus really will be on improvements in sperm quality. And this would be a multi-center study in about 180 men with idiopathic male infertility, and it would be a 3-month treatment phase. Now, if that study is also positive, St. George Street would at that stage license the drug back to the pharmaceutical company so that they can then conduct the larger phase 3 trials and get the fully that then allows the drug to progress to patients. Now, in terms of our timelines within St. George Street, this table just shows time across the top, divided into quarters, so years divided by quarters, and then the 2 studies that we are planning to run, Primer, the phase 1B, and Attain, the phase 2. And we're in the protocol development stage right now for the phase 1B. Our aim is to get the first patient into the study of the year and have that study completed around about the end of Q3 2022. We'll then begin the phase 2 study just as soon as we can, as soon as we've got a positive readout from the phase 1B study, and the phase 2 should complete around about the end of 2024. Now, there are several things that we are doing to try to accelerate this process. First of all, we've already made enough drug product to cover both studies, so we won't have any delay with the manufacture of new product. We're also planning to talk to the MHRA and get their scientific advice on the design of the phase 2 while the phase 1B is ongoing, so that we can have a really robust protocol. And we'll also talk to other doctors and patients about the design of the study so that it's really fit for purpose. It works for those that are going to be involved in it, and that should also drive the quality of the study when it's up and running. So that just gives an overview of how we intend to conduct the clinical development plan. In summary, treat idiopathic male infertility would clearly be a game changer, even if the tablet was only effective in a proportion of the men, because it would still alleviate the burden of IVF on women and on the NHS and on other healthcare systems around the world. As you've seen, there's a strong rationale for investigating the potential of this drug in IMI, both from the strong hypothesis and also, of course, from the data that's been generated at Ninewells Hospital. And last but not least, you've seen that we have a good plan in place to accelerate the development of this product through stage of clinical trials. So if you'd like to keep in contact with us as we continue this, you'd be welcome to follow us on Twitter or LinkedIn, or visit our website where we post updates. And I'd be very happy to return to a future webinar and provide another update, perhaps with Dr. Martins de Silva, when we've got the results of our first trial.
Tiffany is the Chief Executive and co-founder of Dyneval.
So what I'm going to be talking about is really what is in the pipeline for assessing semen quality. And more specifically, I'll be talking about motility, the ability for spermatozoa to move. The company name is an abbreviation of dynamic evaluation. And so we call it Dyneval. We named it ourselves, so we probably need some branding advice. So the company itself is only a year old, and we're still in quite early stages, but we were absolutely a month ago to win the top biotech award at the Scottish Edge competition. Because what we have is an innovative new technique for assessing video microscopy of spermatozoa. So we're able to obtain from those video images reliable measurements of semen quality using a portable device, which is being held very nonchalantly by my co-founder, Vincent Martinez, in this photo. And at the moment, we're focusing on livestock reproduction. So providing this piece of kit vets and farmers so that they can assess semen straws that they use before artificial insemination to make sure they're using really good quality semen and can improve conception rates. But of course, we have an interest in human fertility too. So over the next year, with support of Dr. Martins de Silva, we'll be performing human validation, and a really keen is involved with that. But as a background, although I have the name, well, the word doctor in front of my name, I cannot be responsible in any medical emergency because I'm a doctor of physics, like my colleague Vincent Martinez. And we're actually physicists who study complex fluids. And you might be thinking, what is a complex fluid? Well, essentially, it is a liquid with microscopic bits in it. And these microscopic bits move around due to the motion and the buffeting from molecules surrounding them. And this is called, and this is the sort of environment that spermatozoa are having to swim in. So they also have to propel themselves with a flagellum to get through the medium that they're in. And this medium isn't just a simple liquid, it also has other components in it, including sort of just heads without flagella and just bits of debris within the. But also, as complex fluids physicists, we also understand the signals that come from aggregation and the interactions with other objects. And so my colleague Vincent has developed a really clever way of separating out different kinds of motion. So then we can measure the percentage motility of the spermatozoa without having to worry about the debris, and also the average progressive speed. So how is semen motility measured at the moment? Well, the method for assessing semen quality hasn't really changed since it was invented in 1677. And so it seems a little bit remarkable that despite the rise of computers, IVF clinics and andrology labs are still depending on visual assessment performed by humans. And the technicians are following World Health Organization guidelines, having to count up to 200 spermatozoa twice to obtain cell counts and also the percentage motility. Also, they'll look at other aspects such as morphology. And the whole system is controlled in terms of the quality through Norcross accreditation, where standard videos are shared across laboratories, and the whole system ensures that the technicians' assessments do not vary beyond 10% of the mean. So the key aspects of this are that it's a manual method that can take up to 30 minutes. The uncertainty is controlled to be within 10%, but that's still quite a big uncertainty when the range is 100. And it's a good method for assessing a large range of concentrations, but it does take a significant time to train new technicians to be able to perform these sorts of assessments, over 3 months before they're allowed to do it. And actually, when we speak to technicians, they really only feel very experienced when they've had sort of 5 years of working on this. And I really rely on the visual assessment to actually choose the course of treatment that they will offer couples. So it's really critical that they're getting a good assessment. And another difficulty is that the man has to actually either produce the sample at the clinic or has to deliver it quickly after producing it. And so this actually really slows down the number of samples that can be assessed through this method. In 1985, computer-aided semen analysis was introduced. And this essentially used lab equipment, so a very stable microscope and computer algorithms to actually identify each spermatozoa within quite high magnification microscopy. Between video frames, these spermatozoa are tracked, so the system is able to track paths and identify paths for semen that is progressively motile, so is really making progress in its movement. And it will separate them out from those that are just doing tight circles, for example. So this is kind of a semi-automated process because the lab technician will still need to kind of select and deselect maybe bits of debris that have been picked up. So while the computation is pretty rapid and happens within 30 seconds, there is that need for technicians to be involved. And the uncertainty is still around 10%. However, one of the big problems is that the lowest concentration that can be measured is around 10 million per mil. So this means that it doesn't really work for the subfertile men who have much lower concentrations. And that is possibly about 30% of semen samples produced by men. And so this really ends up being a research tool used in laboratories. So in terms of what Dyneval has developed, we have an innovative technology that is not relying on seeing individual spermatozoa. We're looking at the noise and the intensity fluctuations within the image. This applies statistical physics to actually analyze this intensity fluctuation and back out of that information about the percentage motile and the average progressive speed. So the nice thing about this technique is that it's completely automated. Once you've actually loaded the sample, you just then need to let the instrument do the measurements itself. And the time taken is around 3 minutes. The uncertainties and the errors that are down to 3%, so that's very good. And we're able to measure down to very low concentrations, around 1 million per mil. So this gives some advantages, being completely automated, precise, and a large concentration range, in addition to being fairly portable. And as you can see, it's pretty much a box similar to the size of a laptop. And here is a comparison of the standard deviation that has been gathered from publications and also through our measurements. So this is a standard deviation in the fertility measurement. And this is across all species. There isn't very much of the human samples in there because we're yet to do that. You can see that the Norcross quality control actually keeps the standard deviation of visual assessment to 10% or less. However, the CASA measurements are quite variable, and the concentration range is about 10 million per mil. And as I think Sarah mentioned before, a man is considered subfertile if the concentration is less than 50 million per mil. So our technology is able to measure a very wide range of concentrations, so it can really pick up those subfertile men measurements. And also it provides precision because we're actually very much able to reduce this standard deviation error in the measurements. I should add those measurements that are slightly higher, that are from the bull measurements, were actually collected using the same batch of bull semen, but on different farms. So they'd actually been stored under maybe potentially different conditions, but even still, we had an error less than 5%. And we see another advantage in that we believe that this technology actually expands knowledge on how sperm moves, because it's sort of leave a sample in there, and it will keep measuring the mean speed and the percentage motility over time. So you can see this sample is starting at around 90 microns a second and is falling over a period of just over 3 hours to a speed of nearly 40 microns per second. And actually, being physicists, we like to work out things like the distance traveled, the speed times time. And you can work out that this one would travel about 70 centimeters in those 3 hours, which to me, as a non-biologist, sounds pretty good. It's also, you can see that it's maintaining its percentage motility at that time and is well above the 40% motile that Sarah was mentioning as a criteria. And so we believe that this sort of technique could be used to tell us more about the metabolic health of spermatozoa. We're looking to potentially do correlations with conception rates, and potentially it will also correlate to nutritional and sperm health and maybe environmental factors. And the measurements can be performed will allow us to understand more about the variability for individual men, and also the way in which potentially sperm health recovers from illness. So really, I don't so much leave a summary, but more some points for discussion, because as a new company, we'd be really delighted to hear more about how precise and portable semen measurement could help the community, such as where would it be used, how often, by whom, and we'd love to hear from potential collaborators.
Last but certainly by no means least this evening, we have Robert Brannigan, Bob. And Bob is Professor of Urology and Head of Male Reproductive Surgery and Men's Health.
I think that this is an area that we've seen some growth and improvement in. And I think what's really exciting is, I'm going to detail, we're starting to see inklings where translational basic science work is going to potentially work its way into the clinical arena. And in the last part of my talk, I'm going to really focus on the future. And it's going to be, describing some of the work of one of my colleagues at the University of Pittsburgh. And so I have no conflicts of interest. So if we take a step back, we find that about half of men will develop cancer over the course of their lifetime. And while I think we tended to think about men with testicular cancer, men with lymphoma as being the male should be thinking about fertility effects, we now know that men, like women, are often delaying their efforts for conception until later in life. And so for that reason, we want to be sure that we're not assuming who might be interested in fertility preservation and who might not be interested. When people are given that diagnosis, when they hear those 3 words, you have cancer, very often they feel like the end is near, that all the hopes and aspirations they'd had to, and accomplishments they wanted to achieve in their life have just vanished. But we know that that's really not the case. If we look at males of reproductive, we find that the 5-year survival rate is actually not only good, it's outstanding. And these numbers have really blossomed and improved very nicely over the last 20 to 30 years. For males 0 to 19 years of age, the 5-year survival rate is 85%. And for males up to 44 years of age, it's 75%. So the point is that the majority of men are going to survive and live beyond their cancer. And we know from an abundance of literature, including work that we've done here at Northwestern, survivorship issues include the desire and the goal to be able to father biological children. So it goes without saying, right, that the cancer therapies that are commonly rendered can have a very harsh and permanent effect on developing germ cells. This includes radiation, chemotherapy, and also the cancer surgeries that are done. We look at radiation therapy doses as low as 2 gray can cause permanent and irreversible azoospermia. And then it's important to note that certain chemotherapeutic regimens can cause temporary downward trends in sperm concentration, as we hear in panel A, with a nice recovery in sperm concentrations over time. But there are other regimens, including regimens that have cyclophosphamide and other alkylating agents that commonly cause permanent and irreversible azoospermia. And for the longest time, in the world of oncology, this is just accepted as a necessary byproduct of cancer treatment. And the thing is that I think realized in the early and mid 2000s is that ASCO, ESMO, and other societies were coming forward and saying, you know what, we can't allow these survivorship issues to sit in the back seat anymore. We need to address them concurrent to cancer therapies. And so ASCO put forth recommendations that have been since updated to now become guidelines, calling for fertility preservation measures to be taken. And these guidelines are really simple. number one, to discuss the risk of fertility impairment at the earliest possible time after a cancer diagnosis is made. And number two, to refer the patient to a qualified if the patient is interested in fertility preservation. Even with these oncology guidelines in place, we found many of us in our local environments that oncologists were giving, pushing back, saying there were really no time to bank sperm. There are too many other acute health issues, and that survival is paramount and really what we should focus on. And then this last point, that semen parameters are poor and that sperm is not worth freezing. There's actually literature from the 1980s looking at sperm cryopreserved and how it functioned. And the fertility rates were terrible. They were very low. In fact, the manuscripts tended to recommend against sperm banking as a fertility preservation measure. But times have changed. As we all know, in the early 90s, we saw the advent of these assisted reproductive techniques, namely IVF, ICSI. And the problem is that our colleagues in the world of oncology just aren't as familiar with these developments as we are. We've got an abundance of literature and a bunch of work that we've done here at Northwestern that have shown that they just don't know what's happened in the world of reproductive medicine. And so around 2005, 2006, the Onco Fertility Consortium was formed. I'm in the back row there. Teresa Woodruff was the founder, and she was a PhD, a basic scientist who put together this very large international global consortium to move the field of oncofertility forward. And she did a wonderful job. And programs around the world were established to help implement clinical fertility preservation. We certainly established a program here at Northwestern. And as a result of that program, we saw a big uptick in fertility preservation consults. We saw an uptick across time in patients banking sperm. All the while, the number of patients presenting with cancer at our institution remained the same. And so we really, felt strongly that these efforts to become a part of the clinical picture with fertility preservation becoming a routine part of oncology care was making a difference. I think one of the last groups, a group that we're still struggling with, are adolescents. Adolescent patients are siloed in pediatric hospitals, and these hospitals very often don't have reproductive specialists like us in the hallways, on the wards. And so we and many others have really deliberately gone out of our way to build bridges. And I think we're seeing an uptick or improvement even in adolescent patients. But one group of patients that still suffers are those who are prepubertal and who can't provide an ejaculated semen sample for preservation. We're going to come back to that in just a minute. I would just say that even for an inpatient in a children's hospital, an adult hospital, most of these men are able to give semen samples by masturbation. And for those men that have other challenges, retrograde ejaculation, anejaculation, these can happen sometimes in men with general infertility or men with a cancer diagnosis. We have other tools to get sperm from those men. Perhaps the most challenging men are those with azoospermia, where they provide a semen sample to bank sperm, but there's no sperm present. And even you can go into the testicle and extract sperm. And this is first described by Schrader and colleagues and has since been implemented. And this just shows a case that we did going into the testicle. You find this testicle been largely replaced by tumor. We found an area here at the lower pole where we're able to go in, extract testicular tissue, and freeze it. In the OR, we took a look at the tissue and did indeed find sperm. That's why we went ahead and froze it. And this patient's sample was used for IVF and resulted in the birth of his son, who's about 8 years old now. And so I think we've seen over time in the clinical arena, internationally, societies weighing in and calling for fertility preservation to really be focused upon. We're seeing ASCO, the NCCN, ESMO, the American Academy of Pediatrics, the ASRM, ESHRA, all weighing in and calling for the importance of this care to be given concurrent to cancer care. Because if we don't, we're going to see men who are permanently infertile or unable to have biological children. We still see those patients each and every month in our own clinic here at Northwestern. So what does the future hold? Well, I think that there are a lot of potential exciting avenues to move forward. And one of them involves these prepubertal boys going into the testicle under an investigational approach or an IRB approved study and removing testicular tissue from them. Again, they don't have sperm that can be for their cancer treatment, but they're still at risk to permanent infertility due to the cancer treatment they're getting. And so the ASRM has weighed in and saying that as long as testicular tissue cryopreservation in these patients is done under an investigational protocol, it's ethical. We just need to make sure that what we're hoping for is that one day the science will catch up to the clinical need and these frozen tissues will be usable. And this is a study that we published here with other authors showing that very often this testicular tissue cryopreservation can be done concurrent to other trips to the OR, such as a biopsy or portacath placement. And this testicular tissue cryopreservation effort was well tolerated with minimal complication issues. I think what's really exciting, and really what I wanted to focus on in this talk, is the following work that Kyle Orwig and colleagues published in Science very recently. And so what did he do? Well, this was a proof of principle study that cryopreserved prepubertal testicular tissue could be grafted back into the organism underneath the back skin or scrotal skin and be used to produce testosterone and produce functional sperm. So how did this work? So the investigators took the testicular tissue, removed this tissue from the organisms. Some of the tissues they froze and then thawed. Others they just used fresh and transplanted again underneath the skin of the back or the scrotal area. And then they allowed the tissue to grow, these grafts to grow and develop. And 8 to 12 months later, they went back into these organisms and harvested this graft tissue. And what was exciting and encouraging, they found that the seminiferous tubules were formed, they were growing, they were developing, there were measurable testosterone levels in these organisms, and there was mature viable sperm present, as you can see here in panel D. But they didn't stop there. They then used this sperm through IVF, through in vitro fertilization, and this resulted in the successful birth of Grady, baby rhesus that was conceived through use of this graft tissue. And so what does this research mean? Is this ready for translation to the clinical arena now? Definitely not, it's not. But I think we're seeing a bridge built here between basic science and the needs, the unmet clinical needs that we're facing with prepubertal males and other males with infertility. There are a bunch of potential issues with transplanting cancer from a specimen back into an organism that need to be addressed. But I think there's hope and interest here, and I think great excitement for this kind of work from where I sit clinically. So I would just wrap up my talk, this brief, saying that from an abundance of work that we and others have done, we know that male cancer survivors generally want to become biological parents. And the best option is to cryopreserve sperm before cancer treatments are administered. And that includes not only adults, but teenagers too, adolescents. And these can be difficult patients to work with, to explain things to, but this work can be done successfully. And for that most at-risk group, the prepubertal group, there's work being done in the basic science arena that hopefully will lead to successful translation down the road. And these are some colleagues that we've done a bunch of work with over the years who I just want to acknowledge and thank. And again, I want to thank you so much for the chance to speak with all of you today. It's an honor to be on the stage with all of these esteemed scientists and clinicians. Thank you, Sarah.
So the first question is Karen Hooton, and that's for Jamie, asking, will you be comparing your results with nutritional supplements that we already know can reduce oxidative stress in men?
Interesting. So it's a good question. I think that the pathology here is leaning towards a reduction in reactive oxygen species being the way forward, rather than trying to add antioxidants. So in idiopathic male infertility, you've got an overwhelming amount of reactive oxygen species, and Dr. Martins de Silva may also want to come in here. So it's kind of overwhelming the antioxidant capacity of the body. And so if we can actually redress the balance by reducing ROS, by reducing the reactive oxygen species, then that should then lead, hopefully, to better outcomes than perhaps have been seen with antioxidants in the past. And I think it's been fairly mixed in the past with antioxidant studies.
And I think while we're on that, so there's a question from, and I apologise to anybody whose name I mispronounce, Aju Sunny, about what are the best antioxidants to take for oligospermia. And I don't know whether, Jamie, you want to answer that, or we go to this, Bob might have some views on that as well.
Yeah, I will defer to our medics that are on the panel for this one, I think.
So, yeah, it's a really interesting one, isn't it? I think Jamie's absolutely right. I think there have been quite a number of studies done looking at antioxidants either as single agents or as in combination with other compounds. I think the problem is that there is a very mixed response to it, and I don't know whether there is one particular that's better than the others, or in fact any of them that work robustly, and that's the problem. If I see somebody in clinic, the use I would give them is to think more about what they're eating and drinking, taking in, a balanced diet with plenty of fruit and vegetables. I think vitamin C, because it's water soluble, is probably safest. So, it's not like there are other compounds like zinc, selenium, vitamin E, and so on that are fat soluble. They're difficult for the body to absorb, to excrete if they are taken for a long period of time, and can end up being sequestered within the prostate and other areas of the body, which may set up in store later, health problems downstream. So if you want to take something, I would probably say vitamin C for the moment. The primer study is really just looking at this new drug as a different approach rather than, in comparison with any other antioxidant supplements.
Bob, did you want to add something to that?
I mean, I'm excited about this work. It's looking at, different mechanism to address this problem. And, what we'll commonly see are couples who are having issues with recurrent pregnancy loss or issues with recurrent failure of IVF, miscarriages. And in particular, when we're seeing elevated DNA fragmentation levels in those patients, we'll put them on antioxidants, but it usually doesn't move the needle much. The traditional ones that you mentioned. So I'm excited about this new pathway, and in some instances we'll go to the testicle because there does tend to be less DNA fragmentation at that level compared to ejaculated sperm. And so this is something that, is emerging, but something that we do. And I would say that there are limited studies showing benefit to this. But, we have limited therapeutic options. And if there's a medication that we can give that would provide the same clinical outcome, as opposed to going to the testicle to get sperm, I mean, that would be a game changer. So I'm excited to see how this unfolds.
Yes, it is exciting. And while we're talking about DNA, sperm DNA fragmentation, we've got a question from an anonymous attendee. What treatments have been shown to improve success rates where there is a high level of sperm DNA fragmentation, specifically with regard to diet, which perhaps we've covered a little bit there, microfluid, sperm sorting, IMSI, PIXI, and reduced abstention periods. And then this person said, our NHS clinic completely disregarded the COMET test results that we provide and claim there's no recommended changes to treatment. So I think perhaps that's one for Sarah in the first instance, and then perhaps we'll pass to Bob.
Oh, that's a really big question to unpick and answer, isn't it? I mean, I think you're right. And I think Bob's already said, the issue here is that there aren't really a lot of robust, reliable interventions that we can do to reduce sperm DNA damage. We don't know what causes it. We don't know why some men are more affected by others. I think the two things that we've touched on already are thinking about ejaculatory frequency. So more frequent ejaculation, that will reduce your sperm count, but it might reduce the amount of DNA damage. Or thinking about testicular sperm extraction, that isn't really a route that our NHS clinic is going down. Again, because it's quite a big, involved and intervention, and the data isn't really hugely strong. But the idea here is that sperm consistently and all the time, they then work their way through the epididymis, and it may be in that maturation process in the epididymis that they are then exposed to this oxidative stress and a more noxious environment that has an effect on the sperm DNA quality. So if you can extract younger, newer sperm from the testicle environment rather than from the epididymis, then that's the logic behind doing that approach. But as I say, it's not embedded in any sort of guidance within NHS services. It might be something perhaps the Americans are more likely to take an approach on, depending on funding and so on.
Do you want to come in on any of those points? Because it was quite a big question.
I think, for, sitting across from a patient, having a conversation, the high impact ways, that was an informed question, by the way. That person asking the question really hit the highlights. But I think in terms of the approaches that are, from where I say, most likely to have an impact, or certainly, smoking cessation. I do think there's a role for diet, weight loss, with getting some benefit in this area for some patients. The literature on varicocele correction, I think, is a bit divided, but sometimes varicocele correction has been shown to improve DNA fragmentation in some series. I'm a little bit less likely personally to go that direction. I mean, you know, that operative approach just for DNA fragmentation, but some of my colleagues will. So I guess that gets us back to this, you know, this investigational agent, which, I mean, again, I'm excited about the prospects for this, given that the run-of-the-mill antioxidants that we have in place now very often don't move the needle much.
Yeah. Okay, so the next question is from Sarah Arrowsmith, another Sarah, and this is for Sarah Martins de Silva. Are there any plans to look into increasing PLC-Z2 expression in sperm, gene therapy perhaps? And then a related question to that from somebody who's chosen to be anonymous, are there any natural ways to improve PLC-Z in sperm?
Oh, great question. So not as far as we know in terms of natural ways to improve or change PLC-Z2 expression. I think what we, as I've already alluded to, is what we know is that sperm are produced on a continuum. And so, you know, the question is there anything that I can do? Is there any supplement that I could take? Is there anything that I could change that come, you know, 2-3 months time is going to make an impact on my sperm expression of this protein? The honest answer is we don't know. From my limited experience, I think the honest answer is I don't think so. I think the gene expression thing is a very interesting one. And certainly more recently, there's been quite a number of case studies reporting different mutations in the PLC-Z1 gene. But it's not, you know, you can have sperm samples with apparently, you know, faulty expression or deficient expression where there's no tick issue. And certainly the cohort of patients, we've had 29 of them sequenced to date. We've not identified any genetic problems in any of those patients where they've been identified to have protein deficiency. So don't know. The simple thing is, you know, well, if it triggers calcium in eggs, should we just get guys to take calcium? No, that doesn't seem to make a difference. So I think it's fair and honest to say we don't really have a huge amount of information, but there's a lot of negatives, unfortunately, in that answer in terms of what we think.
Great, thanks for that, Sarah. Now, the next question I'm going to take is from Rebecca Adams. I'm going to put this one to Bob in the first instance. So she says her husband was born with an undescended testicle, which wasn't operated on until he was 11. After 2.5 years of trying to conceive, they recently had the diagnosis of oligospermia. And her question is, if we have a son via ICSI, will my husband's infertility be passed on genetically?
Yeah, so, you know, this is an important question, an important consideration. And I would say right now that, you know, this notion of an undescended testicle and the causes for that has really not been well pinned down to one, genetic abnormality or change. So I would say that the genetics testing that we have, that we use, that can be used to trace likelihood of inheritance really boils down to Y chromosome microdeletions. And that testing makes sense to pursue in men with sperm concentrations of 5 million sperm per milliliter or less. And also potentially, you know, karyotype issues. So a chromosome analysis would be done. Again, the trigger for that is less than 5 million sperm per milliliter. So, you know, with Y chromosome microdeletions, often there will be an identified change in the genes on the long arm of the Y chromosome. And those changes can be passed on to a male offspring. Again, you know, unless there's a single identified genetic anomaly in your husband, which is not likely to turn up on routine genetic analysis, then I would say the answer to your question is likely no. Could he have some as yet unidentified genetic condition that causes undescended testicle? Yes, but do we see lineages of fathers commonly passing on undescended testicles to son? No, that does not tend to be a condition that we see passed on, in contrast to Y chromosome microdeletions, which are indeed passed on from father to son virtually 100% of the time.
Great, thanks for that, Bob. I hope that's sort of broadly reassuring in a way. for the person who asked the question. So the next couple of questions are for Tiffany. So there's one from Anna Potcholzik saying, did your research group collaborate with people who are in ELSI, so ethical, legal and social implications researchers in the past? And there, it seems that the technique you're describing can really change current sperm analysis practices, so they're quite excited about that. And then there's another question for you, which I'll put at the same time, from Sarah Arrowsmith, which is asking, could this device be used in research to more accurately investigate the effects of changes in environment? And she gives an example of that, e.g. I think O2, hypoxia, glucose concentration on sperm motility. So use it as a bioassay as well as a method to assess sperm quality. So if I can put those two to you.
Yes, so those are two really interesting questions. The first one about working with ELC researchers, to be honest, it's something that I wasn't aware of, and it sounds like a really interesting opportunity that would love to go forward with. And in terms of Sarah's question on changes in the environment, certainly in vitro, we can do those studies. And we've already done a little bit of work on that ourselves, actually, by creating a sort of different media and looking at the response of, say, a batch of sperm to different stimuli. So it's certainly something that our technique is sort of very well set up for, because simply you can just look at how the set it up, so it automatically measures how the sperm moves over time. So certainly those are studies we'd really like to be involved with going forward.
Great. Okay, now the next question that I'm going to take is for Jamie, and that is from Anna Potcholzik again. Could you say a little bit more about St George Street as a charity, and perhaps other organisations that would have similar functions, sort of taking drugs that are paused by the private sector for various reasons, but where there are promising early results, and developing them on for public benefit? So if you could say a little bit more about your work.
Yeah, sure. Well, as far as we know, we're quite unique actually in the space for a number of reasons. We're a charity because our primary focus is to help patients, as opposed to a commercial company, which primary focus has to be to the shareholders. We're not focused on one particular disease type. We're agnostic there. We just want to be where there's a high unmet need, and that's not a commercial decision, that's a patient-driven decision. And we're also unique, and we're looking for products and develop products that have already been through phase 1. So we've already got some good safety data to support us going on into phase 2. And for all those reasons, I think we are unique in the world. Actually, there are obviously other charities that do medical research, but none that do everything that we do at St George Street.
Oh, it's fascinating. That's one of the sort of the side benefits of organising this event, is finding out about your organisation, because it just seems like such a great organisation, and I was really excited to read about it, actually. So moving on, I'm going to take a question next for Bob, and Anna Potcholzik again. If I pronounced her name the same way twice, it'll be a miracle, and if I've got it right once, it'll be a second miracle. So apologies to Anna, but great questions that you keep firing off. So she'd like to know what other conditions would benefit from the fertility preservation therapies for males beyond cancer, for example. What about are there fertility preservation techniques accessible to the same extent for cancer survivors and those who suffer from, say, sickle cell disease and have received chemotherapy? Because sometimes I think we do get too hung up just on cancer and forget about some of these other conditions.
Yeah, I mean, these are important issues. Fertility preservation is certainly not only germane for patients with oncologic diagnosis, but also other diagnoses as well. There are other patient cohorts that undergo stem cell transplantation, for example, besides patients with cancer. And certainly any of those patients, the pre-treatment to prepare for the transplantation involves, usually aggressive chemotherapy that typically destroys germ cells. So those patients want to make sure that they cryopreserve sperm. And then there's this whole area now of patients very often, having surgeries, transgender procedures, where sometimes on the male side, for example, a patient may have bottom surgery where they undergo orchiectomy, or they may undergo medical therapy as part of their treatment, thus potentially damaging the gametes or resulting in removal of the gametes. So many of them are going to want to have a chance to become biological parents down the road. So that's another cohort of patients where there's a lot of initiative, and we're trying to make sure that we're there for them and at their time of need on the front end in providing fertility preservation care.
Great. And she also had a follow-up question about, would you recommend, what timeline would you recommend that people should preserve their tissue for grafts? For example, anyone who can afford it and has a relatively high risk of fertility affecting disease, and high risk diseases where treatment would affect fertility, should freeze the relevant tissues.
Yeah, so certainly at this time, like wholesale population-wide fertility preservation, I don't think would be cost effective. I don't think would make sense, but certainly for those patients at risk. So say, for example, we have a patient who's got an oncologic diagnosis and maybe they're starting out with a more gentle or mild chemotherapeutic regimen where, if you look at the data, they've got high odds of having return to sperm. I think we need to be careful with those patients and make sure that we are taking into account the fact that some of those individuals will have progression of their cancer, and along with that, progression of their chemotherapeutic regimens to more deleterious, more damaging chemotherapeutics and cancer therapeutics. And so that's a group I think we ought to be really careful about, and maybe a little bit more liberal in our fertility preservation efforts.
Great. And then we're running out of time. So I'm going to take a question from Martin Johnson for Sarah. Is there any evidence of epigenetic differences in the PLCZ zeta in the cases where no genetic difference has been found? So is there a difference between the epigenetics and genetics here, do we think?
I think the honest answer is we haven't studied that. In terms of, nor have they looked at the genetics in offspring either, which I thought was where that question was going, if I'm honest. Very recently, at the end of last year, there was a paper published looking at offspring development. I guess that's the other kind of issue, isn't it, is setting up an issue that goes down through the generations. And the largest study, meta-analysis, looking at 380, I think it was, children born as a result of oocyte activation, finding that there were no significant differences compared to about 3,000 controls that had been born for C. So I think the comparison there is obviously artificial reproduction, offspring overall, but using this extra step where it's used judiciously should be supported for those that need it. But I think it's fair to say this is really new territory that we're in. I think it's also fair to say that it's not 100% accepted that even PLC zeta is the sperm oocyte activation factor. There are, as I say, there's PAWP that's still out there in the sort of ether somewhere to kind of be discussed. But I think the general notion, the general consensus of scientific opinion is that it is PLC zeta. But beyond that, the understanding of the epigenetics and the genetics is not really very well defined as yet.
More research needed then. And one very I hope we can answer this relatively quickly, perhaps Sarah and Bob. And this is from an anonymous attendee who's thinking about going abroad for IVF because they can use MAX or microfluid sperm sorting chips in addition to IVF and ICSI. And they want to know why they can't access this in the UK, and so therefore they want to know, and that's perhaps where Bob can come in if he knows about this, is about the effectiveness of this as a treatment. So these microfluid sorting chips. So Sarah.
So microfluidic sorting chips are promising, but are not in clinical use, certainly in the UK. Max similarly is not used. I think the Spanish clinics that I'm aware that do use it, they charge it as an additional extra step, whereas we would use density gradient or swim up as the sperm preparation tool. I'm not genuinely convinced that it adds a lot more to sperm selection over and above just a routine sperm prep that we would do in the UK. And I think this is where the HFEA and the consumer marketing are kind of hot on the cases. You know, is it fair then to add a cost to that, to somebody's treatment, without real true benefit and scientific evidence that that's going to make a difference? And I don't think the evidence is there.
I can see Bob nodding.
Yeah, I mean, I completely agree. I think that it's the same perspective over here. You'll find centers that are offering it, and certainly we've seen reports that, you know, this is making a positive clinical impact. But I just, you know, I don't think there's a consensus within our field yet that you know, this is something that should be implemented widely. Maybe down the road, but at this point, I completely agree with Sarah.